Welcome back, everyone, to this year's CR Arthritis event. I'm Kelly Lendvoy. I'm ACE's VP of Communications and Public Affairs. And today I'm joined by a longtime partner, collaborator, friend of ACE's, Dr. Vandana Ahluwalia. She heads the Rheumatology Division of the William Osler Health Centre in Brampton, Ontario. She sees patients in her Brampton community practice as well as in the combined rheumatology orthopedics MSK clinic at Brampton Civic Hospital. She's also very busy and actively involved in clinical trials and studies related to inflammatory arthritis and has co-authored various articles within this therapeutic area. Dr. Ahluwalia, welcome.
Thank you, Kelly. A pleasure to be here.
Now, the Canadian Rheumatology Association recommends one rheumatologist for every 75,000 people in Canada to ensure everyone gets the best care possible. However, Dr. Ahluwalia, as we know, in the northern and rural regions in Canada, there are far fewer rheumatologists than needed. And this shortage means people can wait 6 to 12 months to see a specialist, compared to 60 or 90 days in southern urban regions of Canada. At a workshop that you're presenting in Winnipeg, you're going to talk about a solution to this. And the workshop is titled Optimizing Care for Patients with Rheumatic and Musculoskeletal Diseases Utilizing Advanced Clinician Practitioner in Arthritis Care, ACPAC program-trained clinicians. Tell us a little bit, I think, to start off at a high level, what are the objectives of the workshop, and tell us a little bit about this concept about expanding the role of arthritis health professionals.
Mm-hmm. So thank you for this opportunity, Kelly. I'm very pleased to discuss the workshop that we're presenting at the CRA this week. And I am joined by Leslie Seaver and Laura Passalant, who are program directors at the ACPAC program for this workshop. So it's a collaborative effort here. So the interesting thing is the ACPAC therapists have been trained for the last 20 years. So this is not a new program. And we have our group has been working with ACPAC therapists for about a similar amount of time. These ACPAC therapists are what we call extended role providers. They have to have at least 5 years of clinical experience, whether they're a physiotherapist, occupational therapist, or a nurse. They would go to this program, and it's about a year long. And over time, with the availability of virtual medicine and virtual care and virtual meetings and things like that, the amount of time that they actually have to spend in the program has been reduced, and there's a lot more things that they can do online or virtually. So I think it's about 5 weeks of actual in-house training where they would have to travel to the program, which is based in Toronto at the University of Toronto. And then the other times they have to spend about another 160 hours in order to complete their program. And that's usually on site where they are working. So generally, physicians who would like to initiate some team-based care in their practice, or perhaps hospitals or in other institutions want to institute this kind of early arthritis clinic, or perhaps an early orthopedic clinic in hip and knee replacement, these ACPAC therapists would work alongside them to do various roles. It all depends on what the problem is that you need to solve. So they can work in many different areas. So the objectives of our workshop is really around understanding the training that these therapists have. They're extensively trained, and they work very well in collaboration with rheumatologists and orthopedic surgeons. We understand the different roles that they play in different clinic situations. And, the important thing is, how can we manage to fund them? Either we self-fund them or they're funded by the institution. So those are kind of the things we are going to be talking about at the workshop this week.
Can you tell our audience what the benefits are for the rheumatologist, for the patient, and for the healthcare system overall, if we can successfully integrate these practitioners into arthritis care.
Right. So for the, let's start with the patients. I think it's really, really important that the patient is obviously the center of care here. And what these ACPAC therapists can do is they can work in many different roles. One of the roles that we've used them extensively in is in triage. So, for example, we get a referral from the family doctor or perhaps another specialist, and oftentimes they don't have a lot of experience in arthritis care. So we might get referrals that say arthritis or joint pain, or perhaps not enough information in order to make a decision as to whether this patient needs to be seen earlier or perhaps can wait a little bit longer. So in those patients which we suspect inflammatory disease, these referrals are sent to the ACPAC therapist to see. And in our case, the ACPAC therapist actually does a physical assessment. So they will take a history, they will enter the pertinent data into the electronic medical record system, and also do a full physical examination in the MSK area. So then these patients, if they have inflammatory disease, are referred to see the rheumatologist within a couple of weeks. In other words, and not waiting a long time, because inflammatory arthritis or autoimmune diseases that are active, we can treat and we can get them into remission earlier rather than waiting, because we want to prevent joint damage. We want them to have healthy lives, and we want to have good quality of life with reduced pain and better function. So the idea is to see these patients early. So they're actually referred to the first available rheumatologist. We have a central triage system where they see the first available rheumatologist, as opposed to waiting a lot longer to see an individual rheumatologist. So we have a collaborative effort there for the rheumatologist. We have an assessment that's done by the ACPAC therapist, and they also have an advanced directive. In other words, they can order tests. They can order laboratory tests. They can order x-rays. And that prepares the patient for the rheumatologist visit. So for example, if we have a new patient with rheumatoid arthritis, if we have all the baseline x-rays done, chest x-ray done, hepatitis serology, ESR, CRP, rheumatoid factor, all of the relevant serology, we make a decision on the first consultation visit to start them on the appropriate medication for their condition, as opposed to having those tests done, coming back a few weeks later. Sometimes we don't have availability in our clinic for another 4 weeks. And in this situation, we can actually start them on medication on the first visit. So that makes a huge difference. In terms of the system, we are seeing these patients earlier. We're treating them earlier. We are preventing joint and organ damage. They use their resources. They're not going to the emergency department because they're still in pain and they haven't been treated yet. They are not being hospitalized for these conditions. So overall, the system as a whole is benefited from reduced costs. So I think there's so many important things that we can take home from this.
So not just the new patient and getting the reducing wait times for new referrals and earlier treatment decisions, help with earlier treatment decisions, but also on an ongoing basis, Dr. Ahluwalia. So how can that that health professional, the ACPAC-trained health professional, how can they help with sort of the ongoing management as well? And I'm thinking, really important issues like adherence. How can they benefit that in that respect too?
Mm-hmm. So there are different roles that the ACPAC therapist can play. So for example, in our role, it's a triage role. We have done what we call a treat to target role. In other words, these patients are followed by the ACPAC therapist alongside the rheumatologist in a separate stream. They see the follow-ups of these patients who have been initially diagnosed, and they see them at follow-up 2 months, 4 months, 6 months. And it's a treat to target strategy to improve their understanding of their disease, to ensure they're taking the medications as prescribed. And they're also engaged in healthy behaviors like exercise program, healthy eating habits, perhaps meditation, yoga, Tai Chi. All those kind of things are very, very helpful in terms of improving MSK health. So I think there is an opportunity to use them in many different roles, and that's another one that I'm describing.
I think just a reminder to our audience, they've heard us talk about, and ACE has also covered in issues of joint health insight, for instance, advancements in this area in different regions in Canada. And I'm thinking of two examples. First of all, in BC and British Columbia, where the government provides funds now for physician extenders in rheumatology practice, such as you mentioned, rheumatology nurses, physiotherapists, and other healthcare providers. And in Ontario, we've seen movement in the last 2 years, some exciting developments that the Ontario Rheumatology Association is achieving by working with the provincial government there to address these disparities in care in Northern Ontario specifically by using ACPAC-trained professionals to help bridge the care gap in Northern Ontario. So we're seeing it roll out in action. So I think it's an exciting time. It's evolving, and certainly your presentation, I think, is going to help raise awareness for these other regions in Canada where we certainly would like to see this practice being applied in other regions of Canada as well.
So I think that rheumatology continues to be an underserviced specialty. It's very important that we encourage physicians to become rheumatologists, treat our patients that we spend a lifetime treating, and we're like the family practice of specialty because we have our patients for a long time. It's very fulfilling and satisfying for the patient and for ourselves. And we are looking at these northern areas that are probably more underserviced than we thought initially, and to use the role of the ACPAC therapist to help us support the care up there is going to be phenomenal. So I'm really excited to see how well that is going to work out, and I'm sure it's going to be successful, and we'll be interested in seeing some of the data coming out of that to help us understand it better.
Dr. Ahluwalia, it's always great to see you and to speak with you. You are one of our leaders in Canada. Appreciate the work that you're doing and taking time from obviously a busy agenda that you have in Winnipeg to join us in our audience. So thank you very much.
Thank you. It's been a pleasure.
And thanks to our viewers for joining us on another episode of CR Arthritis.